Hello and good evening all. Today we are going to continue with the anatomy of the inguinal canal, scrotum and testis. Last time we discussed anterior abdominal wall, and today our lecture basically will talk on inguinal canal. And inguinal canal is an important anatomy because of how it correlates with the pathology and pathogenesis of inguinal hernias and the surgical treatment of hernias largely depends on the knowledge of the anatomy of the inguinal canal. So this is a very important topic of anatomy for surgeons, because without having a good grasp of the knowledge of the anatomy of the inguinal canal, doing herniorrhaphy properly might be a challenging task. So the inguinal canal, by way of definition, it's an oblique passage in the lower part of the anterior abdominal wall above the medial half of the inguinal ligament. Now, this canal is oriented in such a way that in the lower part of the abdomen, you have, if this is the lower part of the abdomen, okay, and assuming this is the inguinal ligament, just above this inguinal ligament, the upper and medial aspect, you have a canal that lies obliquely as the inguinal canal. So it admits passage of structures from the abdominal cavity into the scrotum, basically the spermatic cord. Now, it is about 4 centimeters in length. It is directed downward, forwards, and medially. Sex and age variation. The canal is larger in males, and it's shorter in the early life. Now, what you need to know about the canal in the neonate or children, the canal is so short that the 2 openings are superimposed upon each other in such a way that there is no posterior wall in the pediatric age group. That's why in their age group, we don't do herniorrhaphy. We just do herniotomy, high ligation and excision of the sac. Herniorrhaphy simply means reconstruction of the posterior wall. Now, because in the early life, in the pediatric age group, the canal is short, the 2 openings just superimpose each other. In other words, there is no posterior wall. Hence, you don't do herniorrhaphy, you rather do a herniotomy. Now, describing this canal, it has 2 rings or 2 openings, the superficial and the deep. Okay, this is the deep ring and this is the superficial ring. The superficial ring is called the external ring. The deep ring is called the internal ring. And they lie on different planes arising from different structures. lying obliquely. And these two rings are connected by the 4 centimeter canal that is above and medial the inguinal ligament. You should also note that there is a vessel that is very important, especially in the surgery for herniorrhaphy, the inferior epigastric vessel. This vessel is located medial to the deep ring. We shall see the clinical significance of this vessel in due course, but you should know that the inferior epigastric vessels are located medial to the deep ring. Okay, the canal serves as a pathway by which structures can pass from the abdominal wall to the external genitalia. It is of clinical importance as a potential weakness in the abdominal wall and thus a site for herniation. What are the boundaries of the inguinal canal? This inguinal canal is bordered anteriorly, posteriorly, superiorly, that is the roof, inferiorly, the floor. And it has 2 openings, as we mentioned, the superficial and the deep rings, or the internal, which is the deep, and the external, which is the superficial. Now let's see these borders. The anterior wall is formed by, we shall see the image shortly. The anterior wall is formed by the aponeurosis of the external oblique that is reinforced by the internal oblique muscle laterally. So you should know predominantly the anterior wall of the inguinal canal is formed by the external oblique muscle, but it is reinforced laterally by the internal oblique. The posterior wall, which is the part that is usually defective, is formed by the transversalis fascia. The roof is formed by transversalis fascia, internal oblique muscles, and transversus abdominis. The floor is formed by the inguinal ligaments, a root portion of the external oblique aponeurosis that is thickened medially by the lacunar ligament. Let's see some images. This is the posterior wall. And you should know that the deep ring of the inguinal canal arises from the posterior wall. The posterior wall has the deep inguinal ring, which is situated laterally. And the floor, roof and the floor, and this image is a reconstruction. You can see the roof is removed here. The floor is here shown, but the anterior wall is removed. With this 3D image, you will see the oblique nature of this canal. Now, in your MCQ, you will see a question on the deep ring arising from transversalis fascia. That is true. Don't forget, fascia transversalis forms the deep ring because it forms the posterior wall of the inguinal canal. Now, the superficial ring is formed by the external oblique aponeurosis. Now look at the anterior wall, has superficial ring, which is situated medially. Now, in addition to the previous image we saw, the roof and the anterior wall has been added to the posterior wall and the floor. And you can see how this canal is oriented obliquely. So don't think it's just a canal that has two openings like a cylinder. No, the openings are oriented obliquely. Now look at how the content passes. What is the content of this canal? The spermatic cord. You see how it enters the canal from the deep ring, take an oblique course, coming out through the superficial ring. The contents are spermatic cord in males, round ligament in females. The ilioinguinal nerve runs along the spermatic cord. It's not part of the contents, but they run along. Okay, this is showing the origin of the ilioinguinal nerve. Now, let us see these boundaries and their various structures. Now, the anterior wall, the whole length of it is formed by the external oblique muscle. Please pay attention to this, because you might just see question asking on these boundaries. So you need to know what part of the muscle and the proportion that forms the wall. Now the lateral 1/3 is formed by the fleshy fibers of the internal oblique. You can see just lateral 1/3. Fleshy fibers of the internal oblique. So anterior wall of the inguinal canal is formed by external oblique throughout its whole length, and the internal oblique in the anterior, the lateral 1/3. Now the posterior wall. The posterior wall, the whole length is formed by transversalis fascia. And you remember I told you that the deep ring is formed on the fascia transversalis. The medial 1/3 is formed by the conjoint tendon. Okay? And this conjoint tendon is transversus abdominis and internal oblique. They form, their fibers unite to form the conjoint tendon. So that is a posterior. Have this image, have the mental picture, and no matter how the questions are twisted, you can answer them. The whole length of the floor of the inguinal canal is formed by the inguinal ligaments. The medial end is formed by the lacunar ligament. The medial end, the lacunar ligament forms only parts of the medial end. And the lacunar ligament, as you know, is important boundary of the femoral canal. So it is located medially, but the whole length of the floor is formed by the inguinal canal, inguinal ligament, sorry. The roof. Now, the roof, you should know, it is formed by the arched fibers of the internal oblique and the transversus abdominis muscle. And if you remember, we said the conjoint tendon is formed by the internal oblique and the transversus abdominis when they unite to form a tendon. Okay, let me just show you something so that you understand. Now, for understanding of surgery for herniorrhaphy, I told you that the roof is formed by conjoint tendon, which is both internal oblique and transversus abdominis muscle. Their lower fibers unite to form conjoint tendon. And the floor, that is the lower border, is formed by the inguinal ligaments. Okay? If this is the roof and this is the floor, it means here will be the posterior wall. And the anterior wall will be formed by the external oblique aponeurosis. Now, in herniorrhaphy, there is weakness of this posterior wall. What you do is approximation of the conjoint tendon with the inguinal ligament. That is herniorrhaphy. Reconstruction of the posterior wall to obliterate the defect here is to approximate the conjoint tendon with the inguinal ligaments. And that is what you do basically in herniorrhaphy. Except if you have the deep ring is so wide, then you now add what is called Little's repair by approximating the deep ring that is on this posterior wall. So that is what herniorrhaphy is all about. Now, if you don't know how to identify, okay, this anatomy, understand the anatomy, you see there is going to be problem for you doing the surgery properly. Now, you should know that the internal oblique has three protective mechanisms on the inguinal canal. One, it supports the deep inguinal ring from the front by its fleshy origin. It supports the superficial inguinal ring from the back by its conjoint tendon. And it supports the canal from above through it, arching fibers, shorter mechanism. So this shorter mechanism will contract and make the canal crowded so that there will be no protrusion of content. We've talked about this. The deep ring, it is an oval opening in the fascia transversalis, ½ inch above the mid-inguinal points. Now in your exams, you should clearly know the difference between these two definitions, okay? Mid-inguinal points mid-inguinal point are midpoints of the inguinal ligaments. And their clinical significance. So what is the difference between mid-inguinal point and midpoint of the inguinal ligament and their clinical significance? Okay, let's see the difference. When you say mid-inguinal point, okay, this is the abdomen. Let's assume this is the anterior superior iliac spine. And this is the pubic symphysis. So, anterior superior iliac spine, pubic symphysis. So midway between the anterior superior iliac spine, midway between anterior superior iliac spine and pubic symphysis is called mid-inguinal point. Midway between the anterior superior iliac spine and the pubic symphysis is called mid-inguinal point. What is midpoint of the inguinal ligament? Okay. There is a pubic tubercle here. When you just go below, if you palpate the anterior superior iliac spine, if you palpate the pubic symphysis, you just go below inferior-medially, like 2 cm, you palpate a prominent swelling there, which is called the pubic tubercle. Now, that's between the pubic tubercle and the anterior superior iliac spine is the attachment of the inguinal ligament. So you can see the inguinal ligament is attaching anterior superior iliac spine to the pubic tubercle, and midway between the anterior superior iliac spine and the pubic tubercle is midpoint of the inguinal ligament. Midway between anterior superior iliac spine and pubic tubercle is midpoint of the inguinal ligaments. So now, what is the clinical significance between the two? Now, the clinical significance between the two is for mid-inguinal point. Let's go back to the slide. Okay. Now, it is an oval opening on the fascia transversalis, ½ inch above the mid-inguinal point. So you should know when you are doing a clinical examination, there is what is called deep ring occlusion test. For you to do a deep ring occlusion test, you will occlude the mid-inguinal point. Okay? That is, you go ½ inch above the mid-inguinal point and occlude. So we use the mid-inguinal point to locate the deep ring. If a patient has a hernia, you reduce the hernia. Patient lies supine in a supine position, you reduce the hernia. When you reduce the hernia, you now locate the mid-inguinal point. After locating the mid-inguinal point, you now take your finger to ½ inch above medial to the mid-inguinal point. You now occlude. You now ask patient to cough. Okay, when patient coughs and there is no protrusion, you now lift your finger and ask the patient to cough again and there is protrusion. It means it is an indirect hernia, meaning the hernia is coming through the deep inguinal ring. So that is the clinical significance of knowing the mid-inguinal point. While for the midpoint of the inguinal ligament, if you want to palpate femoral pulsation, you palpate the femoral pulsation at the midpoint of the inguinal ligament. So that is the difference. And those are their two clinical significance. Okay? So let's proceed. Now, it is related inferior-medially to the inferior epigastric vessels. What is the clinical significance of this? I told you. I will inform you the clinical significance of the relationship between the inferior epigastric vessels and the deep ring. It's also during herniorrhaphy. The extent, one, you use it to differentiate direct hernias and indirect hernias. When the hernia is lateral to the inferior epigastric vessels, it's an indirect hernia. When the hernia or the sac is medial to the inferior epigastric vessels, it's a direct hernia. So you should know this. When the sac is lateral to the inferior epigastric vessels, it's an indirect hernia. When the hernia is medial or the sac is medial to the inferior epigastric vessels, it's a direct hernia. And secondly, when you are doing a herniotomy, the extent of dissection of the sac. When you see the inferior epigastric vessels, you know that is the extent of dissection of that sac. You reduce the contents, you excise, you ligate and excise. That is one of the ways by identifying the inferior epigastric vessels. The other way is when you see the preperitoneal fat. So those are the two significance of this anatomy, knowing the relationship of the sac to the inferior epigastric vessels. Okay, now the deep ring, its margins are prolonged around the spermatic cord as internal spermatic fascia. We are going to discuss more on this when we are talking of the spermatic cord. Now, what are the structures that passes through the deep ring? Is the spermatic cord in males and the round ligament in females. Now you know, you remember the genital branch of the genitofemoral nerve also passes through the deep ring. Now, what you need to understand is a peritoneal pouch during the embryonic life protrudes to carry the testis to the groin, to the scrotal sac. So as it carries this pouch passing through all the layers of the anterior abdominal wall, it carries the layers of all those muscles wrapping around itself, giving all the layers of the spermatic cord, which we will see. If you have protrusion of a peritoneal pouch coming through this deep ring, okay, if this is the peritoneal pouch, as it enters this canal, it will pick layer of this transversalis fascia. It will pick layer of internal oblique, okay, sorry, transversus abdominis. It will pick layer of internal oblique and it will pick layer of external oblique. So all this will now form coverings of that protrusion coming out. Now the superficial inguinal ring is a triangular ring in the aponeurosis of the external oblique. Don't forget, the deep ring is formed by transversalis fascia. The superficial ring is formed by aponeurosis of the external oblique. It is related posteriorly to the cojoint tendon. Its margins are prolonged around the spermatic cord as the external spermatic fascia. That is the layer of the external oblique, that protrusion of that peritoneal pouch is carrying. We shall see the internal spermatic fascia, the cremasteric fascia. So as they protrude, they carry layers along. Structures passing through the canal. Okay, as we mentioned, the spermatic cord surrounded with internal spermatic fascia. It's carried that from the fascia transversalis, and the cremasteric fascia, which it carries from the internal oblique, as well as we said the external spermatic fascia, which it carries from the external oblique, and the ilioinguinal nerve, a branch from the lumbar plexus that runs along the spermatic cord. Now, when you are asked the contents of the spermatic cord, remember these threes, okay? The three layers, 3 arteries, 3 nerves. The three facial layers are the external spermatic fascia, derived from the external oblique aponeurosis, cremasteric fascia, derived from the internal oblique, internal spermatic fascia, that is derived from the transversalis fascia. Now, the arteries are testicular arteries, cremasteric arteries, and artery to the ductus deferens. That is artery to the vas deferens. The nerves, genital branch of the genitofemoral nerve, sympathetic fibers, and ilioinguinal nerve. This ilioinguinal nerve runs along, it's not actual content. Please remind me, let's talk about the nerve blocks again, how you block these nerves. The genital branch of the genitofemoral nerve after the lecture, remind me if I forgot, and the ilioinguinal nerve. We've already talked about this. It's just buttressing the point, all the layers, and where they are all derived from. Okay. So this is further showing the content of the spermatic cord. Is a diagram illustrating the origin of all the layers and also showing the contents on this transverse section. Okay, we've explained where all the layers are derived from. Okay, and now you see the contents. Now look at the content. This greenish paint is the vas deferens. Okay, this is an obliterated processus originalis. There's a testicular artery. Okay, all these are venules from the pampiniform plexus. They unite. If you look at this other image here, the pampiniform plexus all unite to form testicular vein. Then you have testicular artery and all the layers we explained. This is the deep ring and this is the superficial ring. And you can see the testis and its covering. And the scrotum, before the skin, there is the dartos fascia. Then you have the skin. After that dartos fascia in the scrotum, then you have the external spermatic fascia, cremasteric fascia, internal spermatic fascia. Then you now meet the covering of the testis that is called tunica vaginalis. Now it is important you understand the arrangement of these layers so that you don't get confused in your MCQs. Now, I told you basically there is the direct and the indirect hernias. When you say hernias, of course, they are abnormal protrusion of a viscous or part of it through a defect on the wall of it containing cavity. That is a hernia. Now, the abdominal cavity contains viscera, the intestine. When it protrudes through the defect into the inguinal canal, that is an inguinal hernia. Okay? So it carries a pouch of peritoneum that forms the sac. Okay, so when we should know the parts of a hernia. The hernia has a sac. The contents of the sac and the covering of the sac. So this is the covering, this is the sac, and this is the contents, which could be intestine. The sac has the mouth, that is the sac now. It has the neck, which is very important, that determines whether a hernia obstructs or doesn't. The smaller the neck, the higher tendency for obstruction and strangulation, and even irreducibility. Then you have the body and the fundus. So the mouth, the neck, the body, and the fundus form parts of the sac. Okay, so when you say an indirect hernia, the herniation occurs through the deep inguinal ring, okay? Then along the canal, coming out through the superficial ring. It may descend down into the scrotum to form a complete hernia. It lies lateral to the inferior epigastric vessels. So let me throw more light on this. You should know that any hernia that enters the inguinal canal through the deep ring, it enters the canal through the deep ring. It's called indirect hernia. If this is the deep ring and this is the superficial ring. Now, this hernia that is indirect could be complete. It could be incomplete. Now, when the hernia enters the canal, descend into the scrotum, the bottom of the scrotum, it is called a complete hernia. When the hernia protrudes or remain within the canal, or just exiting the superficial ring, but has not completely descended into the scrotum, is called an incomplete hernia. So let me give you an assignment. You will check what is bubonocyl, what is funicular hernia. That is an assignment. Though they are straightforward, but you read. So, if you remember what I told you, because the inferior epigastric vessels are lying here, medial to this sac, to the ring. So it means this sac will lie lateral, okay, as they come out before going in this direction. I believe that is clear. So that is about indirect hernia. When you talk about direct hernias, there are hernias that pushes directly through the posterior wall of the canal. It doesn't descend down to the scrotum. It lies medial to the inferior inferior epigastric vessels. Now, this is the deep ring. This is a weakness on the posterior wall. The hernia just protrudes. That is called a direct hernia. In our last lecture, we talked about the Hasselbalch's triangle. We said direct hernia protrudes through the Hasselbalch's triangle, which is bounded. It is bounded medial. If this is medial, this is lateral, this is superior, this is inferior. The medial border of the Hasselbalch's triangle is formed by the rectus abdominis. The lateral border is formed by that inferior epigastric vessels, and the inferior border is formed by the inguinal ligaments. Now, this is the weakest point on the posterior wall of the inguinal canal. So that is the Hasselbalch's triangle. Hernias protrude via the Hasselbalch's triangle. So now we are done with the anatomy of the inguinal canal. So briefly we'll talk about the anatomy of the testis. The testis and epididymis are paired structures located within the scrotum. The scrotum is the skin. The testes are the site of sperm production and hormone synthesis. We'll see what produces the sperm, how the sperms are produced, and the hormones. Now, while the epididymis has a role in storage, so what the testis does is production of sperm. What the epididymis does is storage of the sperm. Okay? Now, it is important to know some certain few points about its anatomy because of your MCQs. The testis is located within the scrotum, of course, with the epididymis situated on the posterior lateral aspect of each testicles. Now look at this point. You should know commonly the left testis. The left testicles lies lower than the right. They are suspended from the abdomen by the spermatic cord. We just finished describing the inguinal canal and the spermatic cord and its content. So it suspends down into the scrotum, carrying the testis. So it transmits neurovascular bundles to the testis. Collection of vessels, nerves, ducts that supplies the testis. Now, it is very important you know that originally the testis is located on the posterior abdominal wall. Okay? During the embryonic development, they descend down the abdomen through the inguinal canal to reach the scrotum. Now, the gonads are located in a site called the gonadal ridge. They descend down following a guide This guide is the gubernaculum. The gubernaculum attaches that gonadal ridge. It attaches the gonadal ridge to the bottom of the scrotum. Now, when this testis is just like a blind man holding a rope, finding its way. So the testis descends through that pathway to the bottom of the scrotum. They carry their neurovascular and lymphatic supply with them. So the gubernaculum is a fibrous cord that connects the fetal testis with the bottom of the scrotum. Okay, and by failing to elongate in proportion, so the rest of the fetus cause the descent of the testis. So when you have any arrest along any side, you have undescended testis. From the posterior abdominal wall, no wonder the testis has its blood supply different from the scrotum. Because the source, the origin, is from the posterior abdominal wall. So its supply will be coming from the abdominal aorta. That's why testicular arteries are branches of abdominal aorta. So they follow this gonadal ridge. From the gonadal ridge, they follow the gubernaculum down to the final sites of descent. Now we should understand the chronology of the descent. At the 3rd month of development, the testis is in the iliac fossa. If there is arrest at the 3rd month by failure of contraction of the gubernaculum, because as the gubernaculum extends from here, it contracts and brings it down. So when there is failure, it's arrest. 7th month, where is it? At the deep inguinal ring. At the 8th month, the superficial inguinal ring. At the 9th month, the upper part of the scrotum at birth is in the lower part of the scrotum. Now, the shape of the testis is ellipsoid. They consist of series of lobules, each containing seminiferous tubules, supported by interstitial tissue. Okay, let's describe what this is all about. Look at the shape, of course. It's ellipsoid in shape. Now, this ellipsoid has several lobules. If you notice, there are several septors from this capsule. This thick capsule that is called tunica albuginea. It penetrates to divide these testes into lobules. This penetration of the tunica albuginea, these are called septa. Okay, the septa from the tunica albuginea divides the testis into several lobules. Within every lobule, you have a seminiferous tubule, coil of tube, that is surrounded by an interstitium. Now, this darkish part is the interstitium. Each lobule has a seminiferous tubule supported by an interstitium. This darkish portion you can see is the interstitium. Now, the seminiferous tubule is lined by what is called Sertoli cells. And the Sertoli cells They aid in the maturation of the spermatozoa. Let's see a lining. Now, if you take an image, a cut of one seminiferous tubule, okay? Look at just one tube. And this is the interstitium. Now, in the interstitium, these cells that are in the interstitium are called Leydig cells. What are their functions? The Leydig cells are responsible for production of testosterone. Leydig cells are located in the interstitium. Don't forget. You will come across that in your MCQs. Where are the Sertoli cells that support the maturation of the sperm? They line the seminiferous tubule. So if you are to take a cut, a section, this single cell here, this yellowish structure you are seeing is one cell. And this is its nucleus. So this cell that line up, all these cells that line up the tubule are called Sertoli cells. You can see how all the sperms, okay, are getting nutrients and nourishment. They depend on the Sertoli cells. You can see how they are attached to the Sertoli cells for maturation. So the Sertoli cells are nursing the germ cells to form matured spermatozoa. So you can see this is a single Sertoli cell with its nucleus. And these are the gametes maturing, getting nourishment from the Sertoli cell. While the Leydig cells are in this darkish area here, that's is called the interstitium, and they produce testosterone. Now, spermatozoa are produced in the seminiferous tubules. Okay, we've seen the seminiferous tubules, how the gamete cells are produced, how they are nurtured by the Sertoli cells. Then they need to be transported out of that site. The developing sperm travels through the tubules, collecting in the rete testis. This rete testis is a network of tubules just adjacent to all the seminiferous tubule. You can see from this seminiferous tubule, they link a network that is called the rete testis. Okay, from the seminiferous tubules, all the sperm cells that are produced, they link to a network of tubules called the rete testis. Now, from the rete testis, you have ducts known as the efferent tubules. They transport the sperm from the rete testis to the epididymis for storage and maturation. So this is the epididymis now. You can see it just looks like a, okay. So this portion now is the epididymis that stores the sperm. You can see, we mentioned at the beginning of the lecture, okay, that it is posterior lateral to each testicle. Don't forget, you have the efferent from the network of rete testis. You have efferent tubules. These are the efferent tubules here that connect to these massive coils here, coil of tubule. Now you should know this epididymis is for storage of sperm. And of course, from this epididymis, you have the vas deferens. Okay? The sperm will move out. Now, the epididymis have three parts. It has the head. This portion is called the head, where you have these coils. Then you have the body, and the tail is the distal portion that connects to the vas deferens. So this is the head of the epididymis. You can see massive coils there. Then there's the body and the tail that connects to the ductus deferens or vas deferens. So that is about the anatomy of the testis. Let's see the covering. Don't forget, I said this fibrous part of this testis that divides into, that sends septors to divide the testis into lobules, called tunica albuginea. Then you have the outer covering of the testis that is called tunica vaginalis. When you hear vaginal hydrocele, it means there is collection of fluid beneath this tunica vaginalis. Okay, the tunica vaginalis is accumulating fluid. Inside the scrotum, the testis is covered almost entirely by the tunica vaginalis, a closed sac of parietal peritoneal origin that contains a small amount of viscous fluid. This sac covers the anterior surface and sides of each testicles and works much like peritoneal sac, lubricating the surface of the testis and allowing for friction-free movement. The testicular parenchyma, we've talked about this, is protected by tunica albuginea, a fibrous capsule that encloses the testis. It penetrates into the parenchyma of each of the testicles with diaphragms, dividing it into lobules. We've talked about this. We also talked about this. The epididymis consists of a single heavily coiled duct. It can be divided into three parts: the head, the body, and tail. The head, the most proximal part of the epididymis. It is formed by the efferent tubules of the testis, which transport sperm from the testis to the epididymis. The body formed by heavily coiled ducts of the epididymis. The tail, the most distal part of the epididymis, it marks the origin of the vas deferens, which transports sperm to the prostatic portion of the urethra for ejaculation. Now, what is the innervation? The testis and epididymis receive innervation from testicular plexus, a network of nerves derived from renal and aortic plexi. They receive autonomic and sensory fibers. What is the vascular? This is very important. Okay, when I highlight a point, I emphasize it has surgical importance. The vascular supply of the testis. You shall see the significance of this vascular supply. maybe I will give you as an assignment. The main arterial supply to the testis and epididymis is via a paired testicular arteries, which arise directly from the abdominal aorta. They descend down the abdomen and pass into the scrotum via the inguinal canal, contained within the spermatic cord. Now, you should know the main supply of the testis is testicular artery. The testes are also supplied by branches of cremasteric arteries. Don't forget the cremasteric arteries, those three arteries we mentioned in the spermatic cord. Where do they come from? From the inferior epigastric arteries. And arteries to the vas deferens, where do they come from? They arise from the inferior vesical arteries. These branches give anastomosis to the main testicular arteries. Now, you should know that the three main supply of the testis are: one, testicular artery, which is from abdominal aorta, which is the main supply of the testis. Cremasteric arteries, which are branches from the inferior epigastric artery and the artery to the vas from the inferior vesical arteries. All these three arteries are anastomosed. The blood supply to the scrotum is different from blood supply of the testis. Please don't forget, the patient have necrotizing fasciitis. Necrotizing fasciitis of the scrotum, which is described as hernias gangrene. Hernias gangrene. Hernias gangrene does not involve the testes because they have different blood supply. The venous drainage is achieved via a paired testicular vein. They are formed from the pampiniform plexus in the scrotum, a network of veins wrapped around the testicular artery in the retroperitoneal space of the abdomen. The left testicular vein drains into the left renal vein. Please pay attention to this. The left testicular vein drains into the left renal vein, while the right testicular vein drains directly into the inferior vena cava. That's why you see varicocele are commoner in the left side compared to the right side. Take note of this. Varicoceles are commoner on the left side than the right side because these veins drain perpendicularly into the renal vein. And of course, when you see patient with varicocele, you should be looking for a tumor in that kidney that is obstructing the drainage. The lymphatics. Since the testes are originally retroperitoneal organs, the lymphatic drainage is to the lumbar and para-aortic nodes along the lumbar vertebra. This is in contrast to the scrotum, which drains into the nearby superficial inguinal ring. So you should know when a patient have testicular tumors, the lymph nodes that are enlarged are the para-aortic lymph nodes, because the drainage for the scrotum is to the inguinal group of lymph nodes. If you are taking a scrotal biopsy, the clinical significance of this, if you are taking a testicular biopsy, please take note. If you are taking a testicular biopsy, you don't go trans-scrotal, because if you go through the scrotum and pick up the biopsy from the testis and come out through the scrotum, you will deposit some malignant cells on the scrotum, and they will be drained through a different route and spread to the inguinal region, to a separate group of lymphatics in the groin. So you go trans-inguinal, okay? So this is very important for you to know. Now, what are some clinical relevance we need to take note of? Enlargement of the scrotum. The scrotal sac is visibly, okay? Sac is very distendable and will enlarge in response to the size of its content. There are a number of causes of scrotal swelling, which could be from inguinal hernia, a complete one, hydrocele. We've talked about vaginal hydrocele. Okay, but you should know congenital hydroceles result from patent processus vaginalis. So you have trickling of the peritoneal fluid into the scrotum because of the patent processus vaginalis. It's just the outpouching of that peritoneum that fails to obliterate. So that gives a communicating hydrocele. So there could be vaginal hydrocele, as we mentioned, if you remember the tunica vaginalis. Then adult hydrocele are often associated with inflammation, trauma, or rarely testicular tumor. So when you see hydrocele in an adult, don't just take it with a wave of a hand. You have to take it seriously. Hematocele is a collection of blood in the tunica vaginalis. It can be distinguished from hydrocele by trans-elimination. Okay, you know hydrocele will brilliantly trans-eliminate, except if the content is turbid or bloody or the sac is thick. Those are the reasons why they will not trans-eliminate. Varicocele, gross dilatation of the veins draining the testis. The left testicular vein is more commonly affected as the left testicular vein is longer, that is one, and drains into the left renal vein at a perpendicular angle. Now, these varicoceles, when you palpate them, they feel as bag of worms. They are described as bag of worms. A large varicocele can look and feel like a bag of worms within the scrotum. Varicocele is quite common in the general population. Its prevalence is estimated at 15 to 25%. Epididymis, epididymitis, is inflammation of the epididymis, usually caused by bacterial or viral infection. So we are going to stop here. We will now move into the question and answer session. Okay, I'm going to allow you to unmute yourself. If you have any question, you can unmute yourself and ask. So thank you very much. If you have any question, yes, you can go ahead and ask your question.
Good evening, sir.
Good
This is Dr. Bello. I have one question actually.
Okay.
About the hydrocele that we just discussed. You said if there's a patent ductus vaginalis, yes? then there would be fluid leaking into.
Yes.
There would be fluid leaking and causing a hydrocele, right?
Yes.
Would this be common in people with ascites as well? If they have that patency, is this something that we would be seeing?
Okay. That is a good question. Yes, any other question?
Not a question, sir. You said to remind you about the nerve blocks at the end of the lecture.
Okay, reminder. Yes. Any other question? Okay, it appears that other candidates are sleeping. Let me go ahead and answer the questions. Now, the first question she asked about patent processus vaginalis. Now, you should know during development, if we are going to talk about the peritoneal cavity, if this is the peritoneal cavity, okay, it protrudes to bring its contents to the scrotum. So, usually, all the neurovascular bundle follows the spermatic cord. Okay? And when you remember, we talked about the gubernaculum and the rest. What happens finally is this protrusion obliterates. Okay, there is obliteration. It will just be an obliterated structure. So when it fails to obliterate, you will now have, because when it obliterates, this covering will now be the tunica vaginalis. Okay? The spermatic cord, the peritoneal cavity. When it fails to obliterate, you have what is called congenital hydrocele. Congenital hydrocele results from patent processus vaginalis. So you have peritoneal fluid just coming in, but ideally, it's supposed to obliterate before the age of 1 year. So if it fails to obliterate, naturally that patient will have what is called congenital hydrocele. The peritoneal fluid will be leaking. When the child lies supine, it trickles back into the peritoneal cavity. And because it is patent, they are prone to having hernia. As they stand, the intra-abdominal pressure increases, it widens the deep ring, and the contents of that peritoneal cavity enters through that patent processus vaginalis into the scrotum. So they will have a communicating hydrocele, they will have hernias. So you should know the difference between communicating hydrocele, where there is patent processus vaginalis. As they lie down supine, the fluid goes back. As they stand erect, the fluid comes back to the sac, so it's communicating. While non-communicating, there is already obliteration, and the tunica vaginalis is secreting fluid, and this is the testis, and you have fluid secreted between the tunica vaginalis and the testis. Okay, so when they lie down, there is no any communication. So going back to your question, where you said if a patient has ascites, does it mean the fluid will leak into the sac? Yes, of course, it will leak into the sac, but you should know normally the processus vaginalis is expected to obliterate within the age of 1 year. If it persists, not even ascites, normal peritoneal fluid will trickle down to cause hydrocele. It doesn't even have to get to that extent of becoming an ascites to cause hydrocele. So that is the question. Is it clear, please?
Yes, thank you.
Then regarding the second question, yes, I said you should remind me on the nerve blocks. Let me just do this because you are all surgeons. Nerve block is called local infiltration. When you are doing angiography, what are your target nerves? You block 3 areas. 1, ilioinguinal nerve, and ilio-hypogastric. They are the same. They follow the same route. 2, you want to block the genital branch of genitofemoral nerve. And 3, your proposed site of incision. Okay, where you will make your incision, these are the sites you block. So in the ilioinguinal nerve, you palpate the anterior superior iliac spine. Okay, if this is the pubic symphysis and the anterior superior iliac spine, you palpate it. You go 2 centimeters, 2 centimeters medial, 2 centimeters downward. So this is the point you infiltrate with your anesthetic agents. Okay, you inject like 10 mils of diluted, that is 0.5% xylocaine in all the 3 layers between the external oblique and the internal oblique, between the internal oblique and the transversus abdominis. So you put so that it will be sufficient. That is the first point. The second point you infiltrate at the root of the scrotum. Okay, you remember the spermatic cord comes. So you just get the root of the scrotum here. At the root, you inject. Okay, so you hold the root of the scrotum and inject 10 mils of diluted xylocaine, 0.5%, to block the genital branch of the genitofemoral nerve. That is the second point you block. Then the third point, your incision, if this is the icis, and this is the symphysis pubis, Okay. The pubic tubercle is here. This is the inguinal ligament. Now, your incision for herniorrhaphy is usually made 2 centimeters above and parallel to the medial 2/3. This is the medial 2/3 of the inguinal ligament. This is the inguinal ligament. You make your incision 2 cm above and parallel to the medial 2/3 of the inguinal ligament. So you infiltrate this line like this, where you are making your incision. Then you now do what is called field block. You just, from this point now, this point of your incision, you direct your needle, infiltrate like a fan. You fan out to block all the field. See, if you know how to do this properly, you do herniorrhaphy without patient feeling pain. If you do herniorrhaphy and patient is shouting, and you said patient is under local infiltration, I'm telling you, you are not doing it properly. If you know the exact points to block all the nerves, and now do a field block, you will do your herniorrhaphy comfortably. I hope this answered your question. Though it's not even a question, I said I want to. Okay, thank you very much, everyone. We've come to the end of today's lecture. And on Monday, of course, you will have your assignment. I believe the assignment is in anatomy. And those who submitted later, after reading all the answers I sent, so just go and mark it yourself and send me the score. If you like, you can mark yourself 100%. I just want to know that you've done it and marked, but I've already sent the answer. So thank you very much for participating. We are going to stop here.
Thank you, sir.
You are welcome.